So fortunately, we don't have to just rely on sort of conventional wisdom and teaching and our gestalt about things, because we're increasingly coming up with more objective tools to help. So decision-making aids are really a part of medicine in every field that's out there, and neurosurgery is no exception. And so more and more we're coming up with data to help support our clinical decision-making. And so these are just a couple of examples of papers that have kind of made an effort to do that. So for example, in the Chiari space, people at WashU in St. Louis drive the what's called the Chiari Severity Index. So that's a way to look at the characteristics of the patient, both clinically and radiographically, and figure out, okay, what's the likelihood that someone is going to get better if they have an operative decompression. And in this particular paper on the left, they kind of tried to tie that into something called the Chicago Chiari Outcome Scale and the motor component specifically. And what they showed is actually they don't correlate all that well. So it may be that the CCOS, we can modify it a little bit to improve it and make it better. But the idea that we're trying to come up with sort of objective criteria to serve as decision aids is an important one. Similarly, the paper on the right, I alluded to this one before, that what they found from a large group of patients is that what correlated most closely with a patient being symptomatic and needing to be decompressed wasn't their tonsil position, but in fact, the position of their obic. So they're really looking, largely at Chiari 1.5 patients or patients who have some movement of the brainstem caudally. So it may be that that's actually a much more reliable indicator than tonsillar position. And then that'll come back into the clinic, right? When I'm evaluating a patient or looking at an MRI, I might think about that in terms of someone who is borderline with regard to whether or not we're going to intervene. Similarly, with regard to scoliosis, there's been a lot of good data that has come out recently, and a lot of this, and you'll see throughout the talk that the Park-Reeves Syringomyelia Research Consortium is a 40+ center group that's been around for almost 10 years now, and has gathered both retrospective and increasingly prospective data to try to really dive deep into Chiari management, symptomatology, any aspect of Chiari with syringomyelia that you can think of. So patients who don't have a Syrinx don't qualify for this registry and studies that this consortium does. But anyone who does have a Syrinx does qualify. And over the last couple of years, it's finally started generating really interesting and important papers that are going to help a lot with decision making with regard to Chiari. So it's a field that's moving along and is very dynamic right now. And some of the best examples of their work thus far are in the scoliosis space. So a couple of papers that they've come out within the last couple of years have basically looked at, okay, well, what characteristics of a Syrinx correlate with having scoliosis? So, it turns out if you have a bigger Syrinx, if you have what's called a holocord Syrinx, so a Syrinx that extends throughout the cervical thoracic spinal cord, that really correlates with someone having scoliosis. So having a small Syrinx, maybe that's not a big risk factor for scoliosis, but a big Syrinx is. Interestingly, the amount of tonsil herniation that a patient has doesn't correlate with scoliosis. And that's something that I think a lot of people had recognized, or at least had an inkling of from their clinical practice. It's very common. We'll see somebody whose tonsillar herniation isn't that impressive, but they have a huge Syrinx and a huge scoliosis. And so they were able to generate data that really backed that up. And again, it's another thing that says the actual extent of tonsillar herniation probably isn't the key to what's going on in a lot of these patients. Then turning that into outcome, for me, this is a really important thing, because a lot of the patients that I see get referred through the orthopedic spine program, because I do a lot of spine work. And basically what they found is that in younger patients who have a curve of less than 35 degrees, if you get them decompressed, then that Syrinx is more likely to collapse, and that scoliosis is more likely to stabilize than if you have a patient who's older, or if you have a patient with a higher magnitude scoli. And that becomes really clinically relevant in terms of operative decision-making, because if I see a 9-year-old kid who's got a 30-degree curve, I'm not going to drag my feet, even if they're asymptomatic. If I see a 14-year-old who's got a 40-degree curve, maybe I'll say, look, if I decompress you, I'm not sure it's actually going to help all that much. So that's a different conversation that we're having with that patient than we are with the younger patient.
Hey everyone, Ryan Rad here from neurosurgerytraining.org. If you like that video, subscribe and donate to keep our content available for medical students across the world.